Welcome to an introduction to the Modified Barium Swallow Impairment Profile. The purpose of this introduction is to orient you to the overall approach, recognizing variation in terms of experience of the clinicians who are taking the training, from very novice clinicians all the way through highly seasoned colleagues. I'd like to start with a few salient points that underline the Standardized Modified Barium Swallow Impairment Profile. An MBS is not a feeding assessment. It's an assessment of swallowing physiology to allow a clinician to make good judgments and estimates about how patients will do using a simulated set of liquid and food consistencies. The MBS is not a pass-fail test. It's way beyond aspiration and penetration. If that's all that we're concerned about, any technician could be trained to do such an exam. The Modified Barium Swallow study, if done appropriately, should provide visualization of oral, pharyngeal, laryngeal, and esophageal components of bolus transport. It should allow the clinician to identify and distinguish type and severity of impairment. It identifies targets for treatment based on the nature of the impairment and response to interventions. It requires a standardized protocol with flexibility, as I'm going to discuss, and standardized interpretation. So many of us have been doing modified barium swallow studies for years, and so we ask ourselves, well, why do we need to change now? Because we know more now. We know much more about the mechanism of swallowing that we did when this was first introduced by the eminent Dr. Jerry Logeman, my mentor, and much of it's based on her science and the science of others going forward. Most importantly, we should standardize in the best interest of our patients. When a patient comes to us with a long history, for example, of multiple surgeries or treatments or swallow studies, they should know what to expect when they come into a fluoro suite. They should know what to expect in terms of the outcome of that examination. If we all do our own thing, the results of one exam to another are non-comparable. Standardization involves implementing and developing technical standards based on the consensus of different parties. It should maximize compatibility, interoperability, safety, reproducibility, what I do and what you do, regardless of our level of experience, transparency, so every clinician knows exactly what you did when you did your swallow study, when they're doing their swallow study, and ultimately improving quality of the exam across clinics and clinical laboratories. Standardization should facilitate commoditization of customized processes, that is, getting things from the laboratory into your clinic, translating our research to clinical practice. We know that standardized practices impact very important aspects of a patient's health and well-being. Lack of standardized practice has been shown to, for example, in this slide, result in variable lengths of stays for patients with similar DRGs, and in this case, nonspecific chest pain. So this has nothing to do with swallowing, but just to demonstrate how throughout the scope of healthcare, standardization has shown to impact the outcome of the patient. A few other key points to remember is that evidence rather than our opinion, that's the way I've always done it, it works for me, should guide clinical decision making. We need to look at a broader range of patient outcomes to better understand the true benefits and risks of healthcare intervention. So for example, the whole penetration aspiration thing. That's very important. Airway protection is hugely important, and it is a part of every swallow study done using the MBSImP, but it is one outcome of a physiologic impairment. So you just have to keep that in mind. We're going way beyond that if we're going to advance patient care. And research priorities should be guided in part by public health need. One problem that we have in our field is the lack of agreement on coding, on how we diagnose dysphagia, etc. And as a result, the coding gives us inaccurate information about how wide the scope of dysphagia is in the United States and in the world. If we had standardized measures to capture dysphagia, both video fluoroscopic measures, quality of life measures, and other health and clinical measures, we would move the field forward toward better informing payers and regulators about the extent and pervasiveness of this impairing condition. So, according to a report called Translating Research into Clinical Practice that was published in and around 2007, and this was just in about standardized practices in general, not necessarily swallowing, they said what you should attempt to standardize is your instrument, your assessment instrument, both in contents and in format. Now, we could say the same thing about voice. We could say the same thing about speech production as well as swallowing. And you select your instrument based on the question that you want to answer. So the MBSImP doesn't make any statement about modifieds are better than fees or better than manometry. This is about one test, if it's appropriate for your patient, and that's the modified barium swallow study. Your data collection, the protocol that you use when you're acquiring data, your approach and your method, we should attempt to standardize. The way you analyze your data and interpret your data. Otherwise, we're talking apples to oranges with one another across clinics. Reporting, how we communicate in a written and oral record the results of our study should be standardized so other care providers, as well as our colleagues, speech pathologists, can understand what it is was the outcome of the exam. The goal, my primary goal when designing the first study to develop the MBSImP, of course, then I didn't really know what it was going to be. I was just trying to see if we could try, within reason, to develop a standardized approach, was that it needed to be valid, meaning it has to measure what it's supposed to measure, both in its content, its construct, and its validity related to things like quality of life and other health indices. It needed to be reliable, meaning if I can score it and you can't, it means nothing. If I can't get it out of the Martin Harris lab to the clinic, then it really is of no value clinically. So we had to come up with something. My goal was to come up with something that was not only valuable for clinical researchers, but very practical, linked to clinical action for you, the clinicians, because I'm a clinician just like you. And whatever it was had to be physiologic-based, not just symptom-based, like penetration aspiration. So we published our first study and have published other related studies since. This work takes a long time. You need big data sets to do this, so you don't see a new publication, every 6 months, every year, because we're very careful about what we put through dissemination. This all started by a good review, systematic review of the literature back in 2004, presented to a panel of experts, multidisciplinary experts, who helped us with consensus on what things we should test during a modified barium swallow and what a scale might look like that could achieve a metric that would help us interpret swallowing physiology. So as a result of our consensus validation panel, these were the components that the group determined there was evidence of their relevance to normal swallowing physiology, so we included them in the proposed tool. And we came up with a metric, a rank order type scale from least, meaning 0, normal, no impairment, to the most impaired score. We developed a standardized protocol because if we're going to develop standardized measures, we have to be using the same consistencies to assess physiology across clinics and labs. I mean, we've known from multiple works in the literature by many authors the influence of bolus characteristics on swallowing physiology. So we included those that had been tested in the past and had been recently standardized in the Veribar line, now by Bracco Diagnostics. And this is the protocol that we use. Now, keep in mind that when we first did this study, we were very strict on our protocol. And the reason is because we were doing a study and we wanted to be very careful. We still maintain this protocol, but understand that there is flexibility based on your clinical judgment. You just always have to be, weigh how much outside of the validity of the tool are you going to go in terms of scoring. So this is the protocol. So we do thin liquid, 2 trials of thin liquid. The first one we kind of discount. And the reason is that our experience has shown us that first swallow is typically not representative. As many of you know, especially seasoned clinicians, patients do strange things on the first swallow. So we kind of discount that one. We do a cup sip of thin liquid and we do a sequential swallow. Of course, we don't go on if the patient has high impairment within a class of liquid. If they're grossly aspirating on 5 ml, we're obviously not going to go on to a cup sip. We give nectar, 5 ml via teaspoon, a cup sip, and sequential. You notice we don't give multiple trials of each thing. We have to balance radiation safety, and we feel that our data would support we're getting good samples of impairment using this approach. We use honey, thin honey, 5 ml via teaspoon, pudding, Veribar pudding, 5 ml via teaspoon, solid bolus, half of a Lorna Doone cookie with 3 ml pudding on top. We turn the patient in the anterior-posterior viewing plane, and we assess 5 ml nectar via teaspoon and 5 ml pudding via teaspoon. What we did initially is trained a cohort of speech-language pathologists who had varied years of experience. I think in the beginning, the least experienced were 3 years, and the most experienced were probably 20 plus. We trained them in how to use the scoring metric, and we tested their reliability. And what we found during our reliability testing is that the original scale wasn't perfect, and it's never going to be perfect. But the problem was that there were certain scores, like between a 1 and a 2, that the visual eye could not discriminate a difference. And so as a result, we collapsed the 2. Someone could say that you lose some fidelity in a scale, and I guess you do, but you also improve accuracy. So the tool now, when you look at each component, is not balanced in terms of the number of selections per component. And that's because we only included what we got good reliability with. We tested and scored the exam in 350 patients using our standardized protocol, and then we subjected the data to confirmatory factor analysis, and we tested construct and external validity. I show you this slide because, again, this question always comes up, and I know we get so concerned about penetration and aspiration. And again, it's very important, but it's only one component of an MBS. You can look at our original data here, that even though we had statistically significant relationships between the PA scale scores in these 350 patients and our oral impairment and pharyngeal impairment, you see the p-values here. But if you look at this number here, this is a correlation, and if you square this, you get the variation explained in oral impairment by the PA scale, and it's about 5%. The variability explained in pharyngeal impairment by the PA scale is about 4%. The point here is there are many dysphagic patients who don't penetrate and aspirate, who still need your services. So penetration aspiration isn't what we treat the physiologic impairment. So to summarize, penetration aspiration is not a necessary or sufficient measure of impairment, meaning you can have impairment without it, and if that's all you report, it's incomplete. Keep in mind, we use the penetration aspiration scale on every single MBSImP exam. So in conclusion, the MBSImP tool has been developed and tested that captures oral pharyngeal swallowing impairment. It can be used reliably, but reliability is dependent on training, like training. It's why we don't do train the trainer, because everybody should get the same training in order to be reliable. Physiologic impairment fit a two-factor model in our original analysis, oral and pharyngeal, and you'll see that we call them domains rather than phases because they're not arbitrary. You'll see that initiation of the pharyngeal swallow actually factored with the other components in the oral domain, most likely because of the relationship of tongue movement to triggering a pharyngeal swallow. And the esophageal clearance in the upright position, we do look at it. That's all we look at with the esophageal component. It fell out of the analysis because we had a lot of missing data. As you can imagine, there are patients that you can't always turn or view the esophagus. The other thing to remember is that standardization facilitates patient safety. Even though the degree of radiation exposure to our patients during an MBS is relatively minimal compared to other radiographic imaging, we always have to be cognizant of the fact that any radiation exposure is significant. We cannot keep a patient under fluoro and do every single consistency, every single exercise. It's not safe, it's not necessary. A study by Heather Bonilla, a colleague of mine in our lab, looked at the influence of a standardized protocol on radiation safety. And what we found in that study was that the average fluoroscopy time is 3 minutes or less, an average of 2.89 minutes, and we were always between 2.8 and 2.97. So we feel that this is very reasonable. The radiation physicists tell us this is extremely reasonable. So we maintain that the protocol enhances patient safety. And standardization facilitates translation, as I mentioned before, to clinical practice. We know and articulated by the president of AHRQ at the ASHA Leadership Conference a few years ago that variations and inequities in clinical care exist, and that results in difficulties translating any scientific advances, things we find in the lab. Why don't they come to you? You hear about all these fancy new approaches people are doing at, professional meetings, etc., but why don't you ever get them in your clinic? And there are reasons for that, and there are reasons one reason is because of variation in inequity in how that they're translated and disseminated. There are some barriers to translation, and I think as a seasoned clinician, I can really relate to those of you who've been around a while. First of all, we have to be aware of new things that are coming out, so obviously we have to read the literature. Then we have to accept it based on the evidence, and then the big thing is we have to adopt it. And a lot of times people get through acceptance, but they never adopt it. And why don't they adopt it? One is people say, well, I've always done it this way. I've got this well-oiled machine. Why change? And another is that knowledge of evidence remains separate from and not integrated in decisions and actions. And this came from a publication by Green et al. in the Journal of American Board of Family Practice that this is not just a problem with us in swallowing, but in all areas of healthcare practice. We have to think through with an open mind about how we can do things potentially better. Now, all this said, there is a role for systematic variation in some standards, meaning just because we're talking about a recommended standard for conducting the modified barium swallow study does not mean we're being rigid, that you can never deviate from it. You know, I'm a clinician. I know there are going to be times where I'm going to want to, maybe if I think it's really going to give me added information, something else to that particular patient, or an additional swallow, for example. However, in the Modified Barium Swallow Scoring Guide, please look at it. You will see that all these compensations that we do within the context of the exam are not scored as part of the MBSImP score. You can score them to demonstrate how swallow physiology component improves with the strategy, but that doesn't get put in your impairment score, because we're trying to capture impairment in that room and score it so we can compare improvement from one session to another, not just capturing compensation or adaptation. So you do have to use your clinical judgment. It's going to be based on your patient's performance, the setting you're in, and the cognitive communication status of your patient. So, in summary, the standardized MBSImP includes standardized method of training, the protocol that you use, the tool that you use in terms of the probes and interpretation, the vernacular, and how you report your information in order to enhance reproducibility across clinics and laboratories. You're going to enter into our web-based learning environment that's going to take you through our standardized training that we're constantly improving based on the feedback from our users, our end users. We take it very seriously. We've updated videos. We're now using high definition images or highline images from highline recordings, for example. So we're always trying to make this a living, breathing tool that will perfect and continue to perfect over time. You're going to be introduced into the scoring method that we have found enhances reliability between clinicians. You're going to learn to, you'll take a reliability test, for example, after plenty of practice. And you're also going to be introduced to our reporting structure. And, you know, a lot of clinicians stop here, and I think they stop here after their training because they don't really understand all that our report can offer to them. It allows us to enter patient medical history, and most of this is all radio dial, not free text. It goes quickly. What you'll learn once you practice is it takes about 10 minutes to score the MBSImP, and it takes about 10 minutes to enter the report. So it includes medical history, MBSImP study scores, and other related information that is important for HIPAA compliance, for example. It allows you to track the status of your patient's swallow physiology and outcome over time. It allows you to evaluate the success of your management and treatment, and ideally optimizes your care through consistent practices as advocated in evidence-based medicine. This is an example of what the report looks like. Again, this was all auto-populated by point and click. And this, what you're looking up here, is sort of our signature logo, if you will. And what it does is it gives you the number of the component and the score. The number of component, this is component 2, and their value 3, and their value. And it's explained here. So it doesn't just spit out a number. It tells your physician, it tells your colleague what exactly their function was. And this is the heart of the report, which is the table of your scores. And then we've added the ability to compare your most recent examination score to your previous or last report so you can easily track change over time. So do look at the reporting feature. And now we're ready to get started.